All right. Hello, everyone. Welcome to the National Fellow Online Lecture Series. Our lecture topic today is High Yield X-ray Series, Hip and Knee. My name is Dana Sheng. I'm a sports medicine physician at Dignity Health, and I'll be your moderator for today. This lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. And before we get into tonight's talk, I do want to remind everyone of next week's CAQ prep and review with Dr. Matthew Hall. And the goal of this lecture series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced AMSSM members and at times invited guest speakers in a variety of formats. And finally, this is also meant to assist in CAQ exam preparation. Some reminders: make sure to mute your microphone, turn off your video. You can submit questions at any time through the chat function. At the end of the talk, I, as the moderator, will ask the questions during the Q&A based on the questions you submit. And after the program, we would love your feedback. There are a couple ways of doing this. I just want to make sure Dr. Boutin is your screen is still up. Good. So the first way, there's a web link that can be found by going to amsssm.org. So you click the education tab and then select Fellow Online Lecture Series. The link is near the top of the page as seen in the screenshot. And then the second way is by scanning the QR code. It should take you directly to the form to fill out. And when filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker today, Dr. Robert Boutin. Dr. Robert Boutin is a clinical professor of radiology at Stanford and is the director of their Musculoskeletal Imaging Fellowship. He has served as chair of the Musculoskeletal Imaging Program Committee for the Radiological Society of North America and is president of the Society of Academic Bone Radiologists. He has served as guest editor for the Orthopedic Clinics of North America and for seminars in musculoskeletal radiology, as well as editor-in-chief of Current Radiology Reports. He's also been an invited lecturer for RSNA, the International Skeletal Society, AAOS, and the International Society for Magnetic Resonance in Medicine. Dr. Boutin gave a great high-yield X-ray series review for shoulder, clavicle, and elbow last quarter, and we are very excited to have him back today for hip and knee. So welcome back, Dr. Boutin, and thanks so much for being here.
Thank you. I'm excited. And last time we talked about shoulder and elbow, and we talked about a systematic approach to evaluating radiographs that really holds for any place in the body. That systematic approach is easily recalled as the ABCDEs, looking at alignment, so no subluxation or dislocation, looking at bone density, not too dense, not too demineralized, looking at the cartilage or joint space for any joint space narrowing, of course, looking at the distribution of any abnormalities, and looking for any erosion or osteophytes that might point you in the right direction. And then the S at the end for looking at the soft tissues. So obviously it's good to know what normal anatomy looks like on radiography, but the systematic approach of looking at these ABCDEs can be applied anywhere you go in the body, including in the hip. So the alignment and bone density, as well as the cartilage space, look great here, but there is this osseous hypertrophy at a characteristic location, the anterolateral aspect of the femoral head neck junction, that cam morphology associated, of course, with the cam form of femoroacetabular impingement. When it comes to hip anatomy, there are terms that we often use to describe what's going on. Obviously, the acetabulum, the joint space, the femoral head, the greater and the lesser trochanters being key places to know about. And anatomy that comes in particularly handy, especially in adolescence, is the apophyses. There are certain types of pathology that occurs in the apophyses, and in adolescence, the physes and apophyses end up being the weak link in the biomechanical chain. And so it's good, for example, to know the anterior inferior iliac spine is a place where avulsions occur. That is the origin of the rectus femoris. The anterior superior iliac spine, the origin of the sartorius, and of course the ischial tuberosity, the origin of the hamstrings. So that's just a sort of nice uh, starting point as we look at some unknown cases so that you can test your skills. So this patient comes in with pain, abrupt onset, playing soccer, left hip. What's the abnormality? As we look at that symptomatic side and know our anatomy, it's no problem figuring out that this is an avulsion of the anterior inferior iliac spine, the origin of the two heads of the rectus femoris. It turns out that sometimes these fractures will heal, but there will be some hypertrophic bone that is present. Here, it was present actually bilaterally. And although we often are talking about femoroacetabular impingement, there are other types of hip impingement that occur that are so-called extra-articular forms, this being one of them. And this hypertrophic bone, after healing of a avulsion fracture, predisposes patients to subspinous impingement. So that's something to keep in mind. If you don't look for it, it's easy to not see it. Moving along, here we see the anterior inferior iliac spines look okay, but in another athlete with abrupt onset pain, we can see the salient finding is this avulsion fracture at the anterior superior iliac spine. That is the origin of the sartorius. So obviously it's helpful when you have a pelvis and there's only one side that's abnormal. You can compare side to side, as in this case, a 15-year-old boy with acute onset pain. On this left side of the patient, anterior inferior and anterior superior iliac spine look okay. Anterior inferior iliac spine looks okay, but here a big, huge avulsed fragment. And the patient went to MR, usually not necessary, but you can see that this fragment is displaced laterally a little bit and is associated with quite a bit of edema in the subacute setting. So this was a rather large anterior superior iliac spine avulsion. What about this case? 16-year-old woman, young woman with acute onset pain. You can see the normal ischial tuberosity apophysis is getting quite fused, but on this side, there is quite a lot of asymmetry, and that's because this patient had initial tuberosity avulsion at the origin of the hamstrings. Very good. So we'll finish off just by showing again that there's sort of a spectrum of how much bone can be avulsed. Here, just a small amount. This is a more subacute to chronic injury. Sometimes they heal back, sometimes they don't. But this patient had ongoing symptoms referable to the ischial tuberosity related to this hamstring avulsion. Okay, well, let's take a look at this college athlete and see if you see the radiographic abnormality. I'll tell you that she had left-sided hip pain, and your job is to identify the finding and diagnosis based on that finding, and then maybe even suggest what syndrome you might want to be looking for. Well, the finding in this case, although subtle radiographically, is this band of sclerosis at the base of the femoral neck right here. And that allows us to suggest the diagnosis of a stress fracture. And in a young woman athlete, you might want to think about what has traditionally been called female athlete triad, at least until 10 years ago, when it was rebranded in an International Olympic Committee consensus statement as relative energy deficiency in sport, or RED-S. Relative energy deficiency in sport, therefore, in many places has replaced the term female athlete triad, given that low energy availability can affect both men and women, affecting not only bone health, but a wide range of other organs as well, including in men, hypogonadism. That we saw the radiograph on, just to prove it to you and show you the MRI. You can see this band of low signal intensity on this cut, just contacting the medial cortex, but with really intense adjacent bone edema. And as we scroll through these images, we can see this linear low signal intensity gets farther across the cortex, like we saw radiographically. And this is a stress fracture. And this patient was diagnosed with relative energy deficiency in sport. Okay. Here, another companion case, a 22-year-old woman with pain at symptom onset. You can see the radiographs are unremarkable, but 2 months later, you can see there's a little periosteal irregularity and this band of sclerosis. Still pretty subtle, but much easier to see when you're looking in that location and have the comparison. This for sure is another stress fracture and was followed up with an MRI. Of course, when they're touching the medial cortex and are deemed compressive, often they can be treated non-operatively, but if they go all the way across or on the tensile side, surgeons like to be more aggressive. All right, well, we're still hanging with the hip and being very high yield. 42-year-old woman, an intense runner with hip pain. And I'll let you look at that. And think about what you would say the findings are, what the diagnosis might be, and what syndrome this patient might have. Well, the findings in this case, number one, the bones look very demineralized. They look really washed out in general, thin and sparse trabeculation, thin cortices. And this is in a runner, only 42 years old, look too demineralized to be normal. Furthermore, as would be apparent on clinical evaluation, the patient's very thin. There's a paucity of fat and muscle. And if one looks closely, there's some subtle cortical irregularity. Similar in distribution is this sclerotic line, faint and subtle though it is, that is similar to the last exam. So we might suggest a probable fracture based on this, and often the next diagnostic test that we like to get is an MRI for a stress fracture. The one time where these stress fractures are not conspicuous on MRI is in a patient like this, a patient with anorexia. You can see the wasting of the muscle and fat in this person. And sometimes we see these findings that are so characteristic that the radiologist can be the first person to make the diagnosis of anorexia if they're not being seen by a knowledgeable physician like you all. So the question is, posed, if this is the fracture, where is all the bone marrow edema like we're used to seeing, like in the last case? And in fact, if this is a fat suppressed fluid sensitive or T2 weighted image, and you can see the fluid in the bladder is bright, why is the bone marrow just diffusely bright? We look for bright bone marrow on a T1 weighted image without fat suppression, but on a fat suppressed T2 weighted image, the marrow fat should suppress or get dark, and that's why we see the edema adjacent to a fracture so conspicuously. So the marrow's bright, which is not normal. On a T1 weighted image, like we see here, the marrow should be bright, but it's dark, and things flip-flop on the STIR images. Normally, the marrow should be dark, but here it's bright. So it turns out with advanced anorexia, marrow fat is metabolized for energy, and it's replaced by a serous or gelatinous material that has this low signal intensity on T1 and this high signal intensity diffusely on T2 and stir images, and it sort of masks this fracture. We don't see the edema adjacent to the fracture. So long story short, just be aware that not everybody, most, but not all patients have conspicuous abnormality on the MRI. Here's a stir image, and you can sort of see the fracture there. You can see the fracture a little better on the CT image. So serous atrophy of bone marrow, also referred to as gelatinous transformation, and it's seen with an advanced stage of anorexia or in patients with cachexia. All right, here an athlete who had groin pain, and here's the radiograph. 18-year-old athlete. An MR was obtained, and we see that this area of cortical thickening corresponds to this area of edema signal along the periosteum, bone edema in the medullary canal, and then a little bit of high signal intensity within the cortex as well. So what could be doing that? In a young person, when we see what looks like periosteal reaction, a bunch of adjacent edema and something in the cortex, like what might be a nidus, the broad differential diagnosis from an imaging standpoint includes osteoid osteoma, some sort of subacute infection like a Brody's abscess. You wouldn't expect vascular channel to have bone edema, but in an athlete, of course, you want to look for a stress fracture, and that's what was present here. So stress fractures, of course, we're most commonly looking for in the neck, as we've seen. They can occur a little bit lower, but in athletes, sometimes when we do a field of view that's coned down to the hip, we don't get the proximal femur, and these are missed initially by the radiologist because they're outside the field of view for a small field of view hip exam. So this femoral shaft stress fracture, and just be aware that these can occur in the cortex. Look for the periosteal reaction and the bone edema and periosteal edema. People believe that this is sort of on one end of the spectrum of adductor insertion avulsion injury or thigh splints. We've all heard of shin splints, but thigh splints also are well described, affecting the medial femoral shaft cortex, proximal third, at the insertion of the adductor longus and brevis. And there's sort of a spectrum of stress injury, starting with bone edema and periosteal reaction, and then it can go on, as in this case, to involve the cortex, just like we see more frequently in the tibia. Here, a young athlete, a 13-year-old boy presenting with hip pain, came in with the MRI. There's something there. It's really hard to see anything radiographically. Maybe there's a little sclerosis there, but I think it would be difficult to call prospectively. And just so that we're thinking about the broad spectrum of things that can occur in an athlete presenting with hip pain, we might want to have a differential diagnosis from an imaging standpoint for a reason. So not all linear lucency on CT represents a fracture. Certainly it's characteristic, but when we see linear lucency and a bunch of adjacent sclerosis and what looks like a nidus in the bone, we should also be thinking about the possibility of an osteoid osteoma in a young patient. And again, this is not perhaps as common as a stress fracture in a collegiate athlete in the proximal femur, but these osteoid osteomas often are delayed in diagnosis because people aren't really thinking about them. They're often pretty small, and CT is the best diagnostic test because we can see the really small nidus here with little calcification in it. And they commonly have a so-called vascular groove sign. So they're hypervascular. They have a little vascular channel that feed these things. So just in the differential diagnostic universe, we do think about osteoid osteoma in the appropriate setting, because obviously the treatment, the management is much different than for a fracture. This patient went on to be treated with a radiofrequency ablation. All right, moving on to this patient who was trying to work out, an older person. She had really been trying to take care of herself, 73 years young, and taking bisphosphonates for her uh, osteoporosis. The radiologist was given the history of hip pain and interpreted these radiographs as showing mild OA in both hips. They got sent in for further review. And if you look at the findings, you can make the diagnosis and suggest possible next steps for management. So the salient finding here on the AP view is small but mighty. You can see this beaking of the subtrochanteric cortex, lateral cortex. And although you don't always see it in these cases, certainly there is this prominent linear lucency that you can see on the frog leg lateral view, again, located in the subtrochanteric region, traversing the bone. So a serious diagnosis, an atypical femoral fracture, often associated with chronic bisphosphonate use. And so don't be fooled just because they are doing better than their peers with a good bone density on their DEXA scan. It turns out that the reason they had good bone density is because they had been on bisphosphonates for more than 7 years. They should have had a bisphosphonate holiday. But now it turns out that they've got this fracture. One pro tip is that if you see this finding on one side, it's a very, very good idea to look at the other femur, because in about half of all cases, they're bilateral. Well, in this particular case, the patient came into the ED 3 weeks later, sudden onset pain. Here was their CT and their radiograph, and you can see they now have completed their fracture. It's displaced, they're angulated, and this is much harder technically for the surgeon to address. And so we need to keep our eyes peeled for those before they complete and displace. So is there anything else that we should be looking at? Well, Murphy's Law being what it is, we have to look for a stress fracture on the contralateral side, even if the radiographer taking the radiograph is trying to hide it with their marker. There is this subtle linear lucency in the contralateral cortex. And the very first image that I showed on this patient before the fracture had completed on the contralateral side showed this bump. So beware of this beaking, lateral femoral cortex, because these stress fractures can have big consequences. They're often easier to see, or just as easy to see on radiographs as on CT or MRI. But here's what they look like, involving lateral cortex with adjacent edema. So these patients typically get a long femoral rod or nail. This patient was not displaced on this side, but they were treated prophylactically with a big cephalomedullary nail construct, and you can see on this other side they were reduced. So look bilaterally for these, because it's nice to catch them before they displace. Well, here is another athlete, a middle-aged athlete, not putting in a lot of miles, but might present to a sports medicine practice. The question is, what are the findings? What's the diagnosis? And what are the next steps you might be thinking about? So AP radiograph of the left femur shows this sort of sclerotic focus abutting the lateral cortex. There's sort of this subtle central lucency that appears to be present. And it turns out that as metastases get bigger, unlike a bone island, also called an anastosis, the sclerotic mets become less homogeneous than cortical bone. So a bone island should be compact bone, should be really dense, including centrally. And so we would be concerned in a 50-year-old woman about a blastic met. Where do blastic mets come from? In a woman, most commonly, it's going to be a breast primary. Other GI and GU tumors, besides prostate, can do it like carcinoids. But when we have a sclerotic lesion like this, what are our next steps? Well, radiologists don't have that many friends, unfortunately. And we often say a radiologist's best friend is an old exam. So the cheapest and most efficient thing is to look for any existing imaging exam before jumping to getting another exam like an MRI or asking for a follow-up exam in 3 months and have the patient worry. So it turns out that this patient actually had pelvis radiography done 2 weeks earlier. And in addition to this area of sclerosis, we see another area of sclerosis here. And the question is whether you agree with the radiologist's outside report. They said there are non-aggressive appearing lesions, possibly due to old trauma or degenerative change. Well, an MRI was performed, and you can see something called a halo sign. So here's that sclerosis, but then here's this bright T2 signal adjacent to not just one, but actually 2 lesions involving the hip. And this halo sign is something that is seen with metastatic disease rather than a bone island. And so it just turns out that when opening up the field of view on the MRI, the more we looked, the more we saw these areas of marrow replacement indicative of metastatic disease. And this was an initial presentation of breast cancer. So even though they were coming in for, with this history of trying to do some health maintenance and exercise, it was a breast met or 2 that could be identified on the radiographs. And one might suggest that because bone islands don't have a central lucency, and bone islands don't have a halo sign like we saw on the MRI. All right. I think we're seeing a lot of cases, so hopefully you're having as much fun as I am. Here, another AP radiograph, this time a 51-year-old woman. What are the findings? What's the diagnosis? And what might you do next? Well, this is something that you will see at some point. Characteristic cortical erosion and amorphous soft tissue calcification. It turns out that this is in the distribution of the linea aspera and as a characteristic diagnosis, but an MRI was performed showing this erosive change at the posterior aspect of the femur, the linea aspera, where the gluteus maximus attaches. And after contrast administration, you can see there's a lot of contrast enhancement adjacent to this focus of calcification. That calcification can be more conspicuous sometimes than others, but here's a companion case with an erosion in the cortex and some calcification in a 37-year-old runner. And again, on the MRI, it looks a little bit scary. until you realize that it's characteristic in location uh, for something that we see all the time in the shoulder, but also can occur in this location. Uh, Namely, when we see amorphous calcification like this, it is characteristic of calcium hydroxyapatite crystal deposition. We see it all the time with rotator cuff calcific tendonitis or tendinopathy in the shoulder. It's the same phenomenon here. And follow-up 2 weeks later, you can see it's not some chondrosarcoma or something that's getting worse, but rather the calcification has resorbed, the cortex is now thickened and healing. So certain things happen in certain places preferentially, and this was simply calcific tendonitis involving the gluteus maximus insertion site, with the linea aspera here being a characteristic location. Obviously, calcium hydroxyapatite crystal deposition can incite a bunch of edema, causing those symptoms. Here's another example of that shown with radiographs, this time superficial to the greater trochanter at the gluteus medius insertion. Again, this amorphous calcification. Follow-up 4 years later show that the calcification is penetrating the bone. And we see that in different places like the shoulder, but also in the hip. And when that occurs, it incites a bunch of bone edema in the adjacent bone. So just be aware that this, if you haven't seen it before, it can sort of be a confusing appearance, but this is the way calcific tendonitis looks, whether it's in the shoulder with the rotator cuff or in the so-called rotator cuff of the hip, uh, the adductor tendons like the gluteus medius and minimus. So, quick reality check. Can you name some of the cases that we've seen so far? So, what's this? Well, this is an avulsion of the anterior inferior iliac spine. What's this? Well, that's our stress fracture in a young collegiate athlete with red S. Here's a 42-year-old woman with red S, but with anorexia that's really taking its toll, a lot of demineralization or osteoporosis, and an even more subtle stress fracture and cortical irregularity. Here, one of those stress fractures that occurs most commonly with chronic bisphosphonate use, more than 5 to 7 years, some trochanteric beaking at the lateral cortex. Don't forget that sometimes, although it's unusual, it's not that unusual for people to present with mets when they haven't been diagnosed with a primary. And then calcific tendonitis can occur in different places, not just the shoulder, but also around the hip. So let's, in our time remaining, talk a little bit about some knee radiographs. One thing that is good to look for is a joint effusion. So obviously, when you have a large effusion like this, it distends the suprapatellar recess. And it has been said that if you see this soft tissue density in this location that's more than a centimeter, an effusion is present. If it's 5 to 10 millimeters, there's a possible effusion. This patient over on this side does not have any substantial effusion. There's probably a lick of fluid right here, but not much at all. Okay, what else can we look for when it comes to a radiograph? Basic important stuff to make sure you look for in a traumatic setting on a cross-table lateral view. You can see the interface between blood in an effusion, a bloody effusion or hemarthrosis, and fat that floats on top. I know about how fat floats better every year firsthand when I get in the pool. So here is fat floating on top of this bloody effusion. A lipohemarthrosis is something caused by a fracture until proven otherwise. There are other possible causes, but of course, one sees a lipohemorrhosis, you better worry about a fracture. One other quick thing to show here is we'll look at a couple of ACLs in a second. Here's a nice normal anterior cruciate ligament. It's parallel or even a little steeper than the roof of Blumensatz's line. It's nice and taut. Normal signal intensity. A lot of times you get a little bit of signal distally as it flares out to attach on the tibia. And when it tears, you see the proximal stump often looking unhappy with an area of discontinuity between sort of a lax proximal stump. Here's this discontinuity. Here's the distal stump that's lax and looking pretty horizontal compared to the slope of Blumensatz's line. So normal ACL and an ACL tear that's complete. So this patient comes in and wants you to look at the radiographs, valgus injury on the field. They had a lipohemorrhosis, and the question is, what's going on? The most common misdiagnosis, the most common thing that radiologists get sued for, I will tell you, is missing fractures. And so, even though we're looking for them, they sometimes are pretty hard to see, even if you do it all day long in a dark room, let alone if you're busy in clinic seeing patients. So what is the cause of knee pain after injury in this case? Well, because a diagnosis was not made and the patient had a lipohemorrhosis, you can almost imagine the lipohemorrhosis here, sort of this fat fluid level. But the axial view of the patellofemoral compartment, you actually get a little look at the tibial plateau here, and there's this fracture line that corresponds to what's seen on the CT. On the radiograph, it's hard to see this sort of dye punch lesion that occurred with this valgus injury. So valgus injury, MCL injury, but then the lateral femoral condyle gets driven down. And you can see that there's just sort of some subtle sclerosis here as the trabeculae and cortex are sort of impacted together, but it's a tough call. So if you see a lipohemorrhosis and the patient has ongoing symptoms, you might think about some advanced imaging. It can be, if you're in a hurry and it's more available, a CT, of course, and that will often suffice for getting the patient to the OR for an ORIF. Here just showing that patient again, lateral view, it's really tough to see, but here is the depressed fracture. So in these patients, it turns out that if they were outpatient and you could get it quickly, an MRI is obviously going to show these tibial plateau fractures well. They show depression that's just as good as a CT. Benefits of the MRI might be that you can see bone marrow edema, so you know that it's acute. You can see internal derangements like MCL and ACL injuries. And just as a reminder, when there's bone impaction, that results in a lot of bone edema. But when there's bone avulsion, there may or may not be bone edema to call your attention to an abnormality on MRI. So for example, in this case, a history of a twisting injury, rule out bucket handle tear was the history provided. And we do see what looks like a big effusion here. You can see I've sort of covered it up, unfortunately, with the history, but it goes way up there. So big effusion. You're thinking there might be an internal derangement with this twisting injury in the big sudden onset effusion. And although sometimes if you're just taking a quick look, you may not see it. If you look closely, you will see small fragments such as this in a characteristic location, and we all know that this represents a second fracture. So these second fractures are small and often hard to see on MRI. Sometimes they're missed on radiographs as well. Here, this one has some edema in the bone marrow and in the overlying soft tissue, but sometimes these avulsion injuries don't have a ton of edema, so just be aware of that. And of course, they're considered essentially pathognomonic for the patient having an ACL tear, even though it's only a small minority of patients with ACL ruptures that have a second fracture. Sometimes people debate, what exactly is avulsed. Probably the easiest structure to remember to call this is the anterolateral ligament, and a lot of literature on that. But essentially, it's an anterolateral ligament avulsion, according to many experts. So on MRI, sometimes people will have mechanical symptoms. They complain that they can't get terminal extension or whatever. Obviously, in the acute setting, it can be hard to examine a patient, get a good Lockman pivot shift exam. And this is sort of a characteristic appearance when the ACL is buckling into the anterior aspect of the intercondylar notch. That often bugs patients and sort of looks like what we see in the postoperative ACL reconstruction setting is a cyclops lesion, focal arthrofibrosis, but this is just the anterior fibers of the ACL. The ACL here is discontinuous, and so these fibers are really lax. We're seeing part of the stump proximally. So here on the adjacent cut, you can see these lax fibers. They look edematous. They look lax compared to that slope of Blumenstadt's line. Here are the proximal fibers, and right here is where they're discontinuous proximal third fiber, sort of a characteristic, most common location. And it's these patients who will not only have mechanical symptoms, but probably their ACLs will not heal back, will not scar down because there's just too much of a gap to make up. Sometimes people have non-displaced ACL tears that will scar down with variable degrees of residual laxity or stability. Okay, well, we're getting towards the end. Hang in there. Here, another young patient with a history of playing soccer, bilateral knee pain, left greater than right. And in this patient, again, missed initially on the radiographs, was this bilateral osteochondral lesion, specifically osteochondritis dissecans, made much more conspicuous on the PA standing view than just the regular AP view. And often these patients go on to MR. Often we talk about juvenile and adult types of osteochondritis dissecans. The juvenile form, when the physes are open in younger patients, and when the physes are still open, most of the time it'll heal if the lesion is stable and they're treated appropriately with non-weight bearing for some variable period of time. But here is that osteochondral lesion with bone edema on both sides. And then 4 years later, the juvenile osteochondral lesion has healed. You can see there's no residual bone marrow edema to speak of, or any residual linear low signal. You can barely see the residua of the abnormality. It's well healed, and the overlying cartilage is looking great. Just to show you two other quick examples of osteochondritis dissecans in a juvenile. Here, again, affecting that classic location at the inner weight-bearing aspect of the femoral condyle, and then here extending over to the more main weight-bearing portion. The cartilage status looks great. It's a stable lesion. We can suggest that we don't see any abnormal fluid signal at the interface between the lesion and the host bone. We don't see any big cysts at the interface. We don't see any break in the cortex across the subchondral bone. This is a stable lesion. It was actually asymptomatic, stable, treated non-operatively. The patient did great. We can contrast it with this case, an adult, 33 years old, presenting with these radiographs and this MRI. And in this particular case, on the MRI, what do we see? We see a patient with fluid signal at the interface between the lesion and the host bone. We see disruption of that subchondral bone plate. We see this sort of incongruity of the osteochondral lesion, sort of fragmentation. And these findings all point to the fact that this is an unstable lesion. This patient underwent surgery. It was indeed unstable. The fragment here, and they went from this initial set of radiographs, and the MRI showed you two years later, after an ACI procedure, having a medial femoral condyle that looked great, and the patient did super well also. So I don't want to take up too much of your time, but I did want to leave time for any questions. I could show one bonus quick case that I found interesting in a 18-year-old male soccer player. This will be the last one, and then we'll open it up for any questions that there might be. Right hip pain. And, you know, so often we see these areas of osseous hypertrophy at the anterolateral aspect of the femoral head neck junction, indicative of CAM morphology, predisposing patients to the CAM form of FAI. And we pretty much always get an MR in these patients to just sort of get a better look at the bone and the labrum and the articular cartilage and so forth. This patient actually didn't get an MR. And so, you know, it seemed like a clinical diagnosis. What could possibly be wrong? You've seen this a million times. And is there anything besides the CAM morphology that was discovered preoperatively on the radiographs? No. Did they get an MRI? No. What do we see here? Oh no, we've got some erosion at the medial aspect of the acetabulum. That's sort of funny. I don't know why we have that. The surgeon goes in, here are the fluoro spots to address this osseous hypertrophy and do an osteoplasty or chelectomy. But it didn't take long before a follow-up visit had these radiographs, and the surgeon was not happy. It turns out that this patient preoperatively had these missed erosions, in addition to having CAM FAI, and postoperatively they got worse and worse. The MRI showed that they had this low signal intensity material causing erosion of the acetabulum and also elsewhere in the joint. And it turns out that in this particular patient, they had really extensive burden of disease. This material extended extra-articularly into the iliopsoas bursa, which normally communicates with the hip joint in at least 15% of normal hips. And it turns out that all this material in the iliopsoas bursa and filling the hip joint was not related to CAM FAI, but rather to what is traditionally called pigmented villonodular synovitis or tenosynovial giant cell tumor, now for the last 10 years being the proper official name. So just some images that I found interesting, cautionary tale that people sort of have a workup protocol for a reason. No MR was done preoperatively on this case. it would have been discovered that this patient had a problem. Uh, and so hopefully this patient will do okay, but it already looks like the hip is not doing great. So why don't we stop there and open it up for any questions?
Thank you, Dr. Boutin. That was great. Lots of interesting examples in there. We have a question from Hunter. Could you comment on objective things you look for on measurements you look at when assessing FAI on X-rays?
Yeah, there are so many measurements in the hip and pelvis, of course. Um, we, on every cross-sectional imaging exam, make a bunch of measurements, including the alpha angle. There's a correlate on radiography that is commonly done uh, for FAI and other young hip patients. We typically get a false profile view radiographically as well. My favorite and I think most useful measurement on an AP pelvis is looking at the lateral center edge angle. So obviously there's a big difference between whether the patient has appropriate femoral head coverage by the acetabulum with a lateral center edge angle between 25 and 39 versus some borderline dysplasia, lateral center edge angle 20 to 25, 24, and 20 or less frank dysplasia, as opposed to having a lateral center edge angle of Weiberg being 40 or more, femoral head over coverage. Other things we look for on radiographs for when we're looking at FAI, whether it's a CAM or pincer type, would include looking for posterior, the posterior wall sign, and maybe we can do another session. We can go over measurements, but looking for just focal acetabular retroversion on an AP pelvis, um, and that being a predisposing factor to FAI. I would say that sometimes it's tempting to try and make measurements on an AP hip rather than AP pelvis, but the measurements like for the lateral center edge angle are based on a pelvis radiograph, not a hip radiograph. So yeah, so I think measurements are potentially a whole uh, lecture series unto its own, but that's sort of my basic take on it.
Thank you. I know you said it would need to be another lecture series, but I was just curious if one of our AP pelvis images that you have, could you just kind of draw
Ooh,
how you would measure
yeah,
the LCEA? Just for anyone
yeah.
who doesn't know.
Open
Sorry to
out.
spring that on you.
No, spring away. So, um, so on a lot of PAX tools, you can bring up a best fit circle. So, it'll create a circle for you much better than I can draw freehand on PowerPoint. And then uh, when that is done, it identifies the center of the circle. And then there's another tool, depending on what PAX or viewer you're using to look at the images, and you just drop a vertical plumb line down to that center of the best fit circle, and then go out to the classic being the edge of the acetabulum. And this patient probably has a little bit of a crossover sign, although you have to be careful about calling acetabular retroversion based on whether they're rotated and different positioning things that I won't get into. But essentially, it's this angle that we're looking at for being between 25 and 39. Less than that, we'd be talking about femoral head under coverage or dysplasia, uh, 40 or more over coverage, and predisposing the patient to a pincer form of FAI.
Thank you for drawing that out for us.
Yeah. And so the reason that it's important that it be an AP pelvis rather than AP hip is just that the radiographic central beam, is here, and it's uh, diverging out to here, and so that's sort of all baked in. Whereas if you have a central ray, for a hip AP that's here, the beam's not diverging, and all the measurements are just based on having that AP pelvis rather than AP hip.
Thank you. You showed us a good example of a bisphosphonate related atypical fracture in a femur. Is there a similar spot around the knee that you've ever seen those in?
I don't know about bisphosphonate related fractures per se. I suspect they could occur, but those atypical femoral fractures are specifically defined as being subtrochanteric, proximal, or could be anywhere more distal on the femur, lateral cortex beaking. I think things that we do see, for example, in the tibia are sometimes we see stress fractures in, say, the medial tibial plateau in a patient who has medial meniscus dysfunction. Maybe the meniscus is extruded, they have a posterior horn root tear, and there's biomechanical overload of the medial compartment, and they get a stress fracture in the medial tibial plateau, again, just looking like a band of sclerosis, in this case, horizontally oriented, due to typically medial meniscus dysfunction and medial compartment biomechanical overload. But I'm not aware of it, of the tibia being affected by bisphosphonates. But if you have a case, I want to see it.
I do not, but if I get one, I will
All
send
right.
it.
Yes.
And then you showed us an interesting example of bony hypertrophy sequelae after an AIS avulsion from an AP view. Is there typically one view of the series that tends to be better, or just kind of depends?
Yeah. So, a lot of times it's sort of a subtle finding. Let me go back to that one just so I can be showing it. The hypertrophic bone is sort of pooching out anteriorly, and so some sort of lateral projection is helpful. So here we go. And so since this is sort of draping out anteriorly, some sort of lateral view is helpful. Cross-sectional imaging, often ends up being the best way to go because we can see exactly where it is. And in young patients, lateral radiographs of the hip and pelvis result in a lot of radiation. So, if they're going to get additional imaging, it may not be really value added, but CT or MR would show sort of the location and what the exactly how much of this hypertrophic bone is present.
Okay, great. I think that's all the questions at this time. But thank you again, Dr. Boutin. That was great. It's excited
Dana,
to
anything for you?
have. Thank you. Thank you, everyone. Hope you have a great night. We'll see you for the next lecture.